Welcome to Ventricular Rhythms. This section will be focusing on all electrical rhythms originating or having to do with what's below the AV junction. Quick reminder on the anatomy and physiology just to warm up. You of course have your four chambers, you have the atria up top and the ventricles below. Within those ventricles, the two items we're going to be most concerned about, other than the muscle itself, is going to be your bundle branches. We really won't be focusing on the bundle of His or the AV junction, those things. It's more of just the bundle branches and the ventricles themselves. We're going to be driving the rhythms that we'll talk about today. To just kind of recap or just give you a rough outline, for the basic arrhythmia folks, it's going to be pretty straightforward stuff with bundle branch blocks, PVCs, VTAC, and VFib. Asystole and PEA. As for the advanced arrhythmia, they are going to learn about some extra items having to do with PVCs, VTAC, as well as idioventricular rhythm and ventricular standstill. Right. And on we go. Bundle branch block, quite simply put, is a situation where there is a conduction delay moving through either, so conduction delay, either the right bundle branch or the left bundle branch. And how do we define that? What exactly is a delay in conduction? How do we quantify it? Well, simply put, it is when the QRS is greater than 0.12. That's all it takes. And this is why we've been measuring it this whole time, is so that when you are going through everything and following the routine, you measure that QRS. If it's greater than 0.12, immediately you know that there's some kind of conduction delay going on with the bundle branches. As we go through the ventricular stuff, you'll learn more about that as we go. But if all things being simple, just a wide QRS is all it takes. For those who are curious, in order to truly define the difference between a right bundle branch versus a left bundle branch block, you need to have a 12 lead EKG in order to do that, because it requires all 12 leads in order to really pinpoint which side of the heart is being disrupted, whether it's the right side or the left side, that kind of thing. Just wanted to add that little fact in there. Bundle branch block rules are actually completely dependent on whatever the underlying rhythm is. Honestly, the rate, underlying, the regularity, underlying rhythm, P wave, underlying, PRI, underlying rhythm. Nothing exciting there. At the end of the day, it's when your QRS is wider than 0.12. That being said, I'm going to take a little bit of time now and focus a little bit closer on how to measure these QRSs. What a lot of it really comes down to is the J point and how to find that. So if you think about a typical clean QRS, the way it's supposed to look, you just have your isoelectric line, you get your R wave, comes down to an S, comes up, you get a nice horizontal line, and then your T wave, correct? Something nice and simple like that. In those cases, it's really easy because you've come back to the isoelectric line and there's a nice sharp point right here, and that is your J point. It's where the S wave has officially stopped and transitioned into a different part. That's all well and good, but reality will show you in time that it doesn't always work out that well. And especially when you have bundle branch block patients, what you may often see is isoelectric R wave comes down, your S wave then goes something like this, where you don't have that nice clean horizontal shelf to tell where does the S wave end and where does the T wave begin. It's just not clear. In cases like this, you essentially come down to two options. The one you're looking at right now, how would I measure this QRS? Well, I would start where I would always start, which is where my R wave begins. The end point, specifically in the one I just drew, would actually be about right here. Because at that point, I transitioned from, because we came straight down to the tip, and then it went up, and then it changed angles. And that point where it changed angles is what I'm looking at. That's where my J point would be. And so because of that, I would measure my QRS from here to here. Not the isoelectric line or anything like that. It would actually be this specific point is what I would use as my marker. One other quick example is if I don't have something quite that clean, and I'll draw it up here in the corner. Try this. If it does something along that line, where I really don't have much in the way of change of angle, it's just one smooth slope across there, what we would do is I would actually use the tip of the S wave as my end point for the QRS, because this whole section here, I don't know what part is S wave and what part is T wave. I can't tell. So for this one, you use the tip of the S wave to measure off of to get your QRS measurement. So from here to here. All right, we'll get some more practice in as we go. What you have in front of you here is sinus rhythm with a bundle branch block. And so what makes it that? Well, you've got your P waves, they're right where they're supposed to be, and you've got one for every QRS, which is really good. But the difference is how wide that QRS is. And if you look at a lot of those other rhythms we've seen today, they're short, they're really spiky, kind of tight together. In this case, they're a lot wider. In fact, if we did some measurements, this one in particular here measures from here to here, which is 4 small boxes. 4 times 0.04 equals 0.16, and normal is less than 0.12. So it has a wide QRS. That's what makes it a bundle branch block. That's all the more you need to know. It's not terribly dangerous, and we'll talk about that in the next slide. Why is bundle branch block important? Simply put, it's not natural. It's not part of the native heart function. You acquire it as time goes on. So if it's present, that represents cardiac change in some way, shape, or form. That's part one. Knowing that leads into the next part of asking the question, is it new onset or is it a baseline problem, acute versus chronic? If it's acute, that means it's happening right now. So if you started your shift without it, and then later in the shift that patient has it, that's a sign that something specifically happened. Whereas if it's their baseline, that's extremely helpful too, because if you know it exists, that will help prevent you from making errors later. That wide QRS can sometimes look like a different rhythm, particularly if the patient's heart rhythm starts going really fast or really slow, things like that. So that's really the big benefits there. That's why a lot of times physicians or other care providers will ask for a previous EKG so that they can compare what did they look like before and after. Clinically speaking, they're asymptomatic. A bundle branch block by itself doesn't necessarily mean any major problems for the patient. Now, as it progresses, in particularly a chronic fashion, that may lead to other problems as time goes on or worsen existing cardiac problems that they already had beforehand, which then brings us to the part of what causes it. Well, ultimately, it's ischemic in nature because you have damage to your bundle branches. How did you get that damage? Well, usually ischemic is the cause. How did that happen? Well, coronary artery disease, poor perfusion to that part of the heart. And if you think about it, the bundle branches are buried really deep inside the heart. Blood flow goes from the outside to the inside of the heart, and that makes them pretty easy to injure sometimes. Other possibilities include cardiomyopathy, where you have a heart that is stretched out or is really thick, and that can be the reason why they're acting up or not functioning as well as they should, and some valvular disease can cause that as well. Even though ACLS doesn't necessarily focus on PVCs, we still can't talk about heart rhythms without talking about PVCs, how to identify them, etc. This is also going to fit in just like the other rhythms we've talked about earlier, where this is a single ectopic focused beat, and once we recognize how this works, that'll help us learn the other types of arrhythmias that can occur in the ventricles. In this case, you've got just one single ectopic beat. It doesn't have to be in this location. It literally can be anywhere within the ventricles that it can occur, front side, back side, anywhere. And that's a lot of real estate, which is why PVCs can look so different, and we'll discuss that as we go forward as well. Ultimately, it's firing prematurely, and that's what initiates that individual complex. So it's a singular location causing a singular event. It's, quite simply put, early, and more importantly, it is disorganized. And what I mean by that is it happens outside the normal conduction system, and the impulse is conducted cell to cell, which, as we know, makes it a slower system of conducting that impulse across the ventricles, and that causes us to have a wide QRS and inverted, I shouldn't say inverted, I should say inverse T waves. And as we go forward, you'll understand what I mean by that. But those are the two big criteria for a PVC. More simply put, wide and bizarre. There we go. So let's walk through a few of these and help you get a better idea of what's going on. Premature ventricular complex rules. The rate really depends on the underlying rhythm and the frequency of the PVCs, because this will disrupt the underlying rhythm, because the ventricles are big, and so the electricity that they put off when they depolarize is enough to throw the rest of the heart kind of out of step. So invariably we'll have an irregular type rhythm with this ectopic beat, so be prepared for that for sure. It is very, very possible you may see a pattern with that, and we'll discuss a few of those items. There's no P waves with these, it's just QRS, that's all there is. Because there's no P wave, you can't measure PRI with the PVCs themselves. Wide and bizarre, those are the two big catchphrases, or the one catchphrase I think you should keep with you as you're looking at these things and identifying them. An important idea to go with that QRS is these two items. It's going to be at or larger than 0.12 seconds, and your T wave is going to be in the opposite direction from the R wave. A quick example of that is something along this line where you've got up, and then it goes something like this, potentially, or you've got one that goes down, goes up real high like this. Those are what I mean by having the inverse T waves, is that your T is down here, but your QRS is up here, whereas in a normal beat you would expect the QRS and T wave to where they're both on the top side. So this is a PVC. In fact, you're looking at sinus rhythm with premature ventricular contraction. It's pretty easy to find because it's this big guy right under here, right? The important things I want you to learn is that it's early. You know, if we were trying to keep with the normal cadence, I would expect the next heartbeat to be here, but instead it happened right here. So it's early, it's big, wide, and of course your QRS goes one direction and your T wave goes another. And we'll talk about why that's important on the next slide. Are PVCs important? The short answer is yes. And you'll notice I kind of changed things up from what I usually do, because this is a discussion that's often had, is PVCs don't matter. You know, we tell the physician or the provider and they don't immediately order testing or whatever. Well, there's a few reasons for that. I want to talk about them real quick. First off is that they are common. In fact, they've done many studies, depends on what you look at, but they did monitoring for 24 hours on healthy people. And that's people without any cardiac problems. 80% of them had PVCs within that 24-hour period. And that's pretty impressive that a healthy person's having PVCs. Well, how can we use that to guide us? Well, think about the populations you care for. If they're being hooked up to a monitor, particularly if they're hospitalized, that could be due to coronary artery disease, that maybe there's something going on along that line, and that's what's causing those. So you really do have to pair the fact that the PVCs are occurring with what's their cardiac status look like, so your coronary arteries. Another interesting point to keep in mind is that PVCs typically don't move much blood, and so that creates a situation where when a PVC happens, there's no blood flow. But then when the next heartbeat comes, there was a little extra time, and so the heart moves more blood. And what happens is you have no blood, and then a big heartbeat, and then nothing, and then a big heartbeat. And it's that big heartbeat that is really what causes palpitations. And that's what makes people feel kind of weird. And so you don't really get symptoms unless you're having a lot of PVCs. That may cause certain symptoms. But for most folks, any kind of symptoms that you feel are secondary to the PVCs and have more to do with just the way you feel. In fact, palpitations can cause people to feel anxious. And when you feel anxious, what do? You feel stressed, which causes you to release catecholamines, which is adrenaline, which does what? If you go all the way back to what adrenaline, epinephrine, norepinephrine do, they increase your heart rate and increase irritability, which makes you more likely to have more PVCs. So ultimately, for people who are otherwise healthy in a cardiac situation and having these palpitations and feeling kind of crummy all the time, if they're really anxious, reassurance is the best thing that you can do for them to try and just help calm them down and feel better. Another fun, important thing that I really feel inspired to share with everyone is that they have done studies. In fact, there was a 1,400 participant study that they did, a study of 1,400 participants, let me rephrase that, where they were on what is considered user versus non-user amounts of caffeine, and found that it didn't affect how often they were having PVCs. So that may actually be good news for some of you, that that's what's going on. Now, if you're someone who drinks a cup of coffee and you start feeling your chest pounding, then you may just be someone who shouldn't be doing that. Other things that can cause PVCs to happen is hypokalemia. That's a huge one, particularly in the hospital. You get someone's potassium corrected to greater than 4.0, and those PVCs tend to just drop right off or greatly improve. Ischemia, adding oxygen. I've seen patients do that. They take off their nasal cannula. All of a sudden they start throwing PVCs because their SATs dropped down below 88. Oxygen back on, SATs above 92, PVCs go away. Of course, a good old-fashioned infarction will do it. Cardiomyopathy, you have a stretched heart, or it's just thick. A stretched or thickened heart is way more likely to throw PVCs as well because it's not laid out in the natural fashion anymore. And of course, medications can do it too. At the end of the day, yes, PVCs are important. It's the patient and what their underlying condition is that's going to drive the way we react to the fact that they're occurring. Ventricular tachycardia. This is a really big one. It's one that gets everyone really excited, and so let's talk about what it is. Honestly, it's just a whole bunch of PVCs really quick in a row. The idea is this. The pacemaker comes from somewhere within the ventricle. And it doesn't matter where. It could be here, it could be over here, it could be right in the center, it could be in the front. It doesn't really matter. What's important is that when this pacemaker kicks in, this irritated site, it is rapid and repetitive. It is just firing as quickly as it possibly can. This usually winds up being outside the normal conduction system, so you get good old-fashioned cell-to-cell conduction, which gives us the wide QRS and inverse T waves that we expect to see. And as we do a couple examples, you'll understand what I mean by that. Another key concept with VTAC is that you oftentimes lose a pulse, and when you lose the pulse, you essentially have no perfusion. Or if you don't lose your pulse, it just gets really, really poor, and that causes patients to become very weak very quickly. Sitting up and walking becomes too much, and they just can't even be able to muster that. Another quick definition, I'll say it because I need to. 3 PVCs in a row equals VTAC. Now, of course, you have to have a rate greater than 100, but that's a super nerdy thing. Oftentimes, when you see VTAC, you'll know it, and that's the idea of this course, is I want to get you guys comfortable with, like, yep, that's VTAC, and then know what to do with it. At its core, ventricular tachycardia is this. It has a rate between about 150 and 200 beats per minute. It's usually very regular, but because of how fast it's moving and how big the ventricles are, it can cause some minor irregularities, but nothing major. Your P waves, you're not going to see them, and if you do, that's not the focus. No P waves, no PRI. But these are the big ones. It's going to be wide and bizarre, just like PVCs are. And in fact, all those different shapes of PVCs, that's exactly what can happen with VTAC as well. Your T wave is going to be in the opposite direction, so it's going to be inverse of your R wave. And you're going to have a nice wide QRS. It's going to be 12 or greater, more oftentimes greater. The only other thing I want to make mention of is that you usually lose your pulse because that rapid heart rate, that's fast. 250, especially when the ventricles are moving that fast, there's not enough time for it to refill with blood, which means it's like when you're bailing water out of a sinking boat. The faster you move that bucket, you're not allowing the bucket to completely fill, and so you're not moving as much fluid. The heart functions very much in the same way. Here is a classic example of ventricular tachycardia. You can see at the start here where it begins a sinus rhythm, and then the patient changes what they're doing. The things I want you to focus on here is that each of these, so this is where it starts and that's where it's end. So that's a single beat through here. That this section here to here is the QRS. This up here is the T wave. And look at how fast it is. You know, we're looking at 300, 150, so we got a heart rate of about 150 or so. So it's fairly fast, but just look at how these teeth go up and down and up and down. That's really what makes VTAC VTAC. It's big, it's wide, and the patient probably doesn't have a pulse. So keep all those things in mind. We'll talk about what to do about VTAC next. Why is VTAC important? Well, the number one reason is that it is a lethal arrhythmia, that it is one that will, in short order, wind up leading to a patient's demise. So to kind of explain that a little bit better if I can, or in a more technical way, I suppose, it would be to say this. You've got CVD, which is cardiovascular disease. So CVD, cardiovascular disease, is what can cause either an MI or these lethal arrhythmias to occur due to poor oxygenation, things of that nature. What happens is you can run into one of two things. It's either going to be, sudden cardiac arrest or death. And the way to kind of separate those out is cardiovascular disease leads to sudden cardiac arrest. And sudden cardiac arrest can present as either VFib or VTAC. And that'll be this right here. So heart disease leads to someone going into cardiac arrest, which is usually VTAC. Well, the big thing is sudden cardiac death is basically when you've had an arrest and didn't survive. And that's what makes this so tricky and so scary is I don't have the exact number, but many, if not more than half of sudden cardiac deaths were the patient's very first sudden cardiac arrest. That they had a heart attack for the first time, went into VTAC, and that's what wound up leading to their demise. That's why VTAC is so important. And what makes it really neat is that it's actually fairly correctable. If it's caught early enough, it's one of those things that if you do the right interventions, survival is a pretty fair chance. So what's your clinical picture? Well, you're going to have that sudden cardiac arrest, SCA, and initially they may just wind up being syncopal. They may just pass out right off the get-go, or they might be in VTAC for a little bit of time, a few minutes, maybe even hours, where it's able to move enough blood and keep them awake and conscious and alive so that our interventions can be more successful. And they're going to have all those great cardiac output symptoms, right? Your shortness of air, chest pain, palpitations. If they wind up doing the VTAC or VFib, though, you could have death within a matter of minutes. Ultimately, the treatments that we're going to do for these folks, specifically in VTAC, but anything along this line, it's going to be, ACLS and BLS type things, which is you're going to look for a pulse. If it's there, you'll do the tachycardia algorithm in ACLS. If it's negative, you're gonna just start compressions. And at that point, you're gonna get your either AED or your defibrillator. And go about your business that way. But compressions is king. That's what's going to really make a difference if someone presents with VTAC. Triggers, what causes it? We talked about this already. Cardiovascular, ischemia, usually from an MI, or potentially structural issues such as cardiomyopathy or heart failure, where the structure and function of your heart has gotten so poor that that winds up being one of the triggers for a sudden cardiac arrest. Ventricular fibrillation. What's the mechanism? What's going on? In this scenario, we have multiple foci that are causing the troubles. And it is just pure chaos. And if you look at these, honestly, what's really going on is each one of these is kind of spinning its own direction and sending out ripples that just overlap with one another. It's like rain in a pond or rain in a puddle. Each raindrop sends ripples out in its own direction and just makes everything a mess. And for these folks, that just makes this terrible fibrillation, these F waves. It doesn't look like much at all. You don't get VFib unless you have some kind of underlying disease. Essentially, always something's already going on with your heart to make it weak and vulnerable to put it in this situation. There is absolutely no pulse with VFib, and that's that. Because of just how weird everything looks, that it's depolarizing and repolarizing all over the heart, every direction. There's no way that it can move blood at all. The only other thing I would say for this is it needs a trigger. That you've already got this vulnerable heart that you just give it one little push and it goes over the edge. So what are the rules for VFib? Well, there really aren't any. It's just total chaos. There's no waves. There's nothing to measure. It's just a mess. The only really finer points to discuss on VFib is the fact that it kind of has three phases. So if you look at the start, there's kind of a middle, and then there's an end. And this is over time. At the very start, it has a lot more energy. There's still calories and everything in the heart, so that your mess looks pretty big. And then you get into this middle phase, and it looks a lot less than it did before. And then in your final phase, it just flattens out completely. And the way we differentiate these is that we say coarse VFib, fine VFib, and asystole. That is the true progression of VFib, is that it happens, it's coarse, and then it gets a little bit flatter, and then it completely flattens out. This can take a matter of minutes. It does not take long at all because there's no blood moving. So essentially your heart has stopped, and how long can your body go without blood flow? That's the logic behind all of this. Here is an example of ventricular fibrillation. And as I had just discussed in the previous slide, it's just chaos. you have no two waves that look identical with one another. Some are wider, some are more narrow, all sorts of different changes. That's what makes VFib VFib, just that constant undulation of everything. And of course the patient has no pulse, which is what makes it scary. You know, this is one of those lethal arrhythmias. Write a couple words in here while you're reading the screen. All right, so what are we up against here? Well, why is VFib important? The biggest part of this is this. When a patient goes into VFib, ventricular fibrillation, they completely lose their pulse. They have a total hemodynamic collapse. They have no blood pressure, no heart rate. And clinically speaking, they're dead because there's no blood flow in the truest sense. How is this significant? Well, it's lethal. It's a lethal rhythm. How does it happen? What did this all come about from? Well, they almost always have underlying cardiovascular disease because it requires a heart that has already weakened, that one more additional insult is enough to push it over the edge and go into VFib. So cardiovascular disease, a triggering event, such as ischemia or something else, causes the sudden cardiac arrest, where the patient winds up having full hemodynamic collapse. They, drop in BP, no pulse, stop breathing, respiratory rate, stop breathing. And that's why they need absolute and total support to survive. Without intervening during the sudden cardiac arrest, you're pretty much guaranteed to have sudden cardiac death instead because they did not recover. BLS and ACLS are huge. Compressions are what's going to make the difference, because when this happens, it's minutes that they have to survive. And so by doing compressions, that buys you time, so we can do our other interventions to help them hopefully have a good outcome. Other triggers other than the cardiovascular disease and ischemia is structural stuff, which is heart failure and cardiomyopathy, and anything else that causes structural issues with the heart that makes it more vulnerable. The last little tidbit I want to add in with this has to do with the syncope, and it's the idea that your sudden cardiac event or sudden cardiac arrest happens. You have total drop in your hemodynamic system, blood pressure and everything stop, and you wind up having a case of syncope, and that is where you literally drop dead because all at once your heart just stops. You pass out, you hit the floor, and they say that phrase like they were dead before they hit the ground. This is what causes that to happen because VFib is so lethal to people. And by the time anyone can intervene, it's been too late. Now, for the most challenging rhythm you'll learn this entire course. All right, that's not true. In fact, asystole is one of the most straightforward ones you can possibly come across. The idea is that the heart has lost all of its electrical activity. There is just nothing being produced by the cells of the heart. If there is anything being made, it is inconsequential. Another way to phrase it is there is no native pacemaker to initiate the pulse. And the reason for it is essentially always because there is no oxygen being pumped to the cells or brought to the cells of the heart to help keep them going. And without oxygen, there is no energy to repolarize. No energy, you can't repolarize, and therefore you can't make an additional impulse. This has a grave prognosis. It's one of the poorest possible outcomes you could think of, or that we've been able to find in terms of cardiac arrest and things of that nature. Essentially, the heart is dead. Other things, nothing coming from the heart. And so a bit of the explanation I want to give just to make sure I don't miss anything. Things that we can do when we try and take care of these types of patients, it's compressions. And then the ambu bag, in that they need circulation and oxygenation provided to them in order to survive. Without that, they have nothing. The rules for asystole are as straightforward as you can guess. This is asystole. It's just a straight line. There's no electrical flow going any direction through the heart, which is why there's no rate, no regularity, no waves, no PRI, no QRS. It's just nothing. And that's why it's such a grave prognosis, is there's just nothing there. I like to include this asystole one just because it's that easy to learn. But I do want you guys to realize when the leads are off or when a battery is drained on telemetry, this is all that the monitor tech sees, and that's very disconcerting. So it's important that you realize that a flat line on the screen is a scary thing. So we always want to make sure that we're evaluating this, making sure leads are on, and all the different things that we can do to help keep monitoring on our patients. Why is asystole important? Well, the patient's dead, so we'll start with that. That's why asystole is important. Either that may be the outcome you were hoping for if it was a withdrawal of cares, comfort cares patient, or it may be completely unexpected, in which case, we need to intervene accordingly to try and correct for it. It's the very, very poor prognosis, and the only way I can explain this well is like if you think about a battery. Just hear me out. So you've got a battery that's just got a little bit of charge left in it, and it's in your phone or a flashlight or a camera, whatever. If there's a little charge left in it, you can turn it back on, right? Like power off the phone, wait a little minute. Okay, I'm going to turn it on just long enough to do one thing and then turn it back off. And it works. And that's what like VFib and VTach are. When it comes to asystole, the battery is completely spent. There's nothing left in it whatsoever. And that means that because it's been completely drained, if you try and turn that device back on, or in this case, you try and get the heart running again, it doesn't have enough charge. It won't even turn on at all. Maybe if you're lucky, it might, but that's very, very rare that occurs. And so in that battery analogy, asystole is a completely drained battery that has very little hope of successfully restarting. Typically, the patient has been in cardiac arrest for some time, and that's why it has degraded to the point where it's at. All you can do is compressions. Bag them. And then maybe try some epinephrine to see if that will help. Triggers, lots of things can cause asystole, and it's pretty much all cardiovascular in nature. So hypokalemia, ischemia, infarction, medications, cardiomyopathy, all those things. Pulseless Electrical Activity, otherwise known as PEA. So what is it? The technical definition is as follows: that any organized rhythm without a palpable pulse or measurable blood pressure. And that's essentially it. So if you look at the screen, this looks like sinus tach, right? You know, you've got your P, QRS, all that looks good. It's ticking right along, but you have no palpable pulse. So that you look on the screen, it looks fine, but you always have to check the pulse. Always, always, always check pulse. And at which point you just do ACLS and BLS interventions if that winds up being the case. PEA gets grouped in with asystole because compressions and bagging are about all you can do to help them. If you know what the insult was that initially caused this, because there's a handful of them, those interventions can be done. But these are the big ones to really keep them going. And that's all there is to PEA. I mean, really not much else to say on it. Which conditions are common in patients with a bundle branch block? Well, you can go back to the slide and reference it, but if you just kind of walk through these, cardiomyopathy, that's where you have stretch or thickening of the heart wall, and of course that's going to make it difficult for that signal to travel and function properly. So cardiomyopathy is definitely one of them. Coronary artery disease, CAD, definitely can be a cause because, you know, poor blood circulation, blood flow, things like that can lead to a little bit of ischemia, which of course can lead to death of tissues. So coronary artery disease is definitely one of them. And valvular disease, definitely. You know, if you're dealing with regurgitation or stenosis and things of that nature, that can change the shape of the heart. Sorry, I get my delta a little bit better. And also make the heart function differently, and that can lead to bundle branch block as well. Or long QT syndrome. This is not on the list. Long QT syndrome is a whole nother thing that has to do with conduction and not necessarily what would cause a bundle branch block. So out of these, you know, it's cardiomyopathy, CAD, and valvular disease. Those are what are more likely to cause your bundle branch blocks. The telemetry tech notifies you your patient was in sinus rhythm, but is now having a lot of PVCs, like every other beat. What first action would be most appropriate? Well, you have to decide, are PVCs important right now? And what the hallmark of this is that it's an increased frequency, and it's a high frequency as well. And that makes it new and unique. And if you recall, the thing that makes PVCs dangerous or really not good is that the more often they're happening, the more it can affect the patient. So with that in mind, is this non-emergent? Would you have a CNA look at them? No, I wouldn't do that. Would I just notify the attending without even looking at the patient? No, I wouldn't do that either. So now you're down to, is this emergent that you need to call an RRT and have the ICU nurse come? Well, no, because again, you need to take a look at your patient first. So now you're down to, is it just you evaluating the patient, then notifying the attending, or to just notify that attending immediately without looking at them? That's off the list as well. So it comes back to that core concept. Anytime you have rhythm changes like this, the primary nurse needs to be the one who evaluates the patient and then notify the attending or whoever needs to take a look at the patient next. The telemetry tech notifies you that your patient appears to be in ventricular fibrillation. What first action would be most appropriate? Well, if your patient's in VFib, we know that that's one of the lethal arrhythmias. So is this non-emergent? Absolutely not. You wouldn't delegate the CNA to go look at this patient. Do you call your attending right away without even looking at the patient? No, we wouldn't do that. Now, while this is emergent, you wouldn't notify the attending without looking at the patient first, so we can take that one off. So now you're down to the primary nurse being the one who evaluates the patient and starting ACLS or BLS if there's no pulse, or do you call the RRT and potentially delay care? Well, I would say don't call the RRT until you've laid eyes on the patient. Your most appropriate first action is going to be you as the primary nurse getting in there, evaluating the patient, and starting that BLS, because minutes matter if the patient truly is in VFib. When providing care to patients in ventricular tachycardia, which of the following are your priorities? And so you have to keep in mind that VTach is, again, one of those lethal arrhythmias. And so when you go in the room, what are you going to do first? Well, you'll visualize the patient, you'll check for a pulse, absolutely. Collect vital signs if you can. If there's no pulse, you're going to initiate CPR. Also try and confirm whether they're DNR or DNI status, because you don't want to start CPR if that's not the patient's wishes. If they're in VTach, are you going to ambulate them to the restroom? Absolutely not. You're going to try and get them in a chair, get them in a bed, have them sit still. You're going to check level of consciousness, and that's part of visualizing the patient, because they may have a pulse and still be conscious enough that you can provide different treatments accordingly. Are you going to move the patient from the floor to the bed immediately if they had some kind of syncope and wound up on the ground? And you're not. You're going to keep them on the floor because that's where they're safe for now. When there's enough help, then maybe you can move them elsewhere. Just keep the scene safe. So again, don't ambulate, don't move the patient from up to the bed, just assess that patient and provide cares. The telemetry tech notifies you that your patient's battery empty alarm has sounded, creating a systole on the monitor. What first action would be most appropriate? And so you have to decide, is that monitor tech really does not know what your patient's heart rhythm is doing now? Is this a case where it's non-emergent and there's no reason to hurry? Is it urgent, where someone needs to get in there and change it as quickly as possible? Or is it emergent, where you need to call an RRT or something at that level? Well, I'm going to take non-emergent off as a choice because we have asystole. The patient's on a monitor for a reason. We need to be able to see that heart rhythm. So this is a little bit higher end, and so you have to decide, is this an urgent matter or is it just emergent? Well, the monitor tech has likely contacted that primary nurse immediately and is really pushing to escalate if it doesn't get corrected soon. So for you as the nurse at the bedside or the CNA, whoever it may be, this is definitely an urgent matter. It doesn't matter who does it, but that battery needs to be changed as soon as possible. The telemetry tech notifies you that your patient just went into ventricular tachycardia, VTach, and is now in asystole on the monitor. What first action would be most appropriate? If you've just been notified that your patient had VTAC and now has asystole, that's 100% lethal and is an emergency, hands down. So we're not going to delegate to the CNA. We won't even notify the attending. That would delay care at this juncture. And again, notifying the attending to come evaluate, that is also going to delay care. Now, you could call an RRT on it and have the ICU nurse come, but that again may cause a delay. The true answer to this is you need to get in there. That primary nurse needs to evaluate the patient and initiate ACLS and BLS if there is no pulse, which is likely to be the case. So, as we've gone over many times, get in there as soon as possible, put eyes on the patient, and start care as quickly as you can. If there's no pulse, then you can escalate accordingly.